We're very excited to welcome you all to the webinar today. Thank you so much for joining us. We have a great panel of experts to talk about their use of ultrasound in their plastic surgery practice, show a couple of specific cases of what normal and abnormal looks like to start you on their path for recognizing in your own office with your patients the information that this butterfly can give you that hasn't been available before. I'll introduce the panel. We'll talk again about most frequent use cases, normal versus abnormal, what those images look like. We'll have a quick demo by a clinical expert and sonographer from Butterfly on the quick use of Butterfly, show how easy it is to get up and running at any point when you need it with a patient. And then again, have a discussion with our panelists and time for Q&A. Let me introduce our panel. First, out of Nashville, Tennessee, the Plastic Surgery Center of Nashville. You probably all recognize and know her, Dr. Melinda Hawes. Dr. Hawes, thank you so much for being here.
It's my pleasure. It's rare that somebody who's been doing this as long as I have has found a new technology that I'm this excited about and excited to share, and it's actually changed my practice. So can't wait to talk to everybody.
Yeah, thanks again. And then next, certainly someone who's been recognized as a leader in both implant research, long-term research, as well as safety research. And in the last couple of years has probably been one of the primary educators for use of ultrasound and plastic surgery within the US plastic surgery community. Pleased to have from St. Louis, Dr. Patricia McGuire on with us. Thank you so much for giving your time for this.
Thanks, Blaine. Thanks for this webinar. I think high resolution ultrasound is going to become standard of care, and having this type of webinar and access to an affordable, very useful and accurate device between you and Butterfly is a great thing for plastic surgeons and especially for our patients.
Great, thanks again, and look forward again to a nice discussion with the two of you on cases. And then also on our panel today from Butterfly is Dr. Jill Kalman. Dr. Kalman is a cardiologist by training and recently was both a chief medical officer and chief executive officer of Lenox Hill Hospital System in New York. Got to manage that through COVID, which I'm sure was a chore. And then after we got through that, she then joined Butterfly as a senior vice president of strategic partnerships, bring a wealth of experience in healthcare to this webinar and to this partnership. Thank you so much, Dr. Kalman, for your partnership with Sientra.
Thank you so much, Blaine, and thanks to Drs. McGuire and Hawes. And I'm thrilled to be part of this webinar tonight. And I think after Blaine does some introductions to Sientra, I'll say a couple of words about Butterfly and this important space. So thanks very, very much.
Yeah, thank you for that. And I'll just to get us started, I just wanted to kind of mention a little bit of the history of why this partnership came about for Sientra. As most of you probably know, Sientra was founded on a principle that we would only sell our breast surgery devices to board certified and board eligible plastic surgeon, i.e. those who are trained and have the correct training to be able to offer great results and safety to their patients. And I think this kind of webinar is a perfect example of that, as board certified plastic surgeons who take the time to continue to educate themselves on innovation and safety, again, to benefit patients. So, Sientra is known for our breast implants, silicone gel breast implants, as well as our tissue expanders. And again, we are solely focused on supporting your practices in plastic surgery. We don't do anything else. There is no pharmaceutical company behind us. We live, die, and succeed through the success of your practices. So if you're not already partnering with Sientra on our devices, I'd love to just give you a couple of reasons to do so, which correlate why this partnership with Butterfly is here, is that we are very, very confident that we offer a different device. And while nuanced in feel, when you just feel it, the long-term safety and the engineering behind it really stands to show a difference with your patients and gives us an opportunity, again, to partner with people like Butterfly. And so on the slide here, just quickly show that in lab testing, we tested the strength or force to fracture of all implants on the market, as well as the softness. And what you're seeing with Sientra's higher slope here is just a more optimized trade-off of that strength or softness curve you get with silicone gel as you cross-link it to become more form stable. So our lowest cohesive, which is still high cohesive strength gel, is as strong as Allergan's most cohesive, but far softer and priced to compete with older generation gels. And our HSC Plus gel is really the strongest gel on the market, has the strongest gel shell integration, and is form stable, but is also not the firmest gel on the market. So again, this difference in gel technology is just a different architectural conformation of cross-link gel gives us a different performance, and that's why we're so confident in our product, and that shows in the long-term data. These were not perfect studies, the FDA core studies to be compared, but in the end, we all did MRI cohorts to look for rupture, and I think this is a really important point that we talk a lot about rupture, but really clinically, there's no way to truly see it. And we all know that patients outside of the clinical studies are rarely getting an MRI, and even MRI has its faults. But seeing that these studies were done similarly, Sientra is a very impressive low rupture rate compared, especially with Mentor's MRI cohorts, which is an older generation gel in both primary augmentation as well as primary reconstruction. And that kind of data is why we can offer a best-in-class warranty, 20 years of coverage, especially for rupture with financial assistance and device replacement. Again, because we know we are only putting these in the hands of those trained to get those great outcomes, and we have giving you the device that's least likely to rupture within 10 or 20 years. So with that, I think that kind of brings us back to the heart of what Sientra's goal is, again, to serve plastic surgery community. And so this partnership with Butterfly comes out of our confidence in our products and our confidence in the safety that patients get through plastic surgeons. And again, allows us to partner, bring this education forward, and use funds to go back into plastic surgery research. So again, thank you for that, for being here, and I hope you're all integrating Sientra into your practice as well. With that, Dr. Kallman, if you'd like to say a few words about the partnership.
Absolutely, and thank you very, very much again, Blaine. And what I really like about this partnership is that it was really created around safety. And that's where we were both companies entirely aligned on what the intent was. And what we're really thrilled about is the ability to empower your community, the surgeons, around safety for your patients, that the ability for Butterfly to screen and evaluate your patients with implants and also evaluate them longitudinally over time. And we know that there's non-compliance with MRI, but what it also, and I think Mindy said this from the very beginning, it changes your workflow, because it allows you to make real-time decision-making in the moment when you're seeing the patient, and then make actionable diagnostic insights. And that probably changes the way you will handle an evaluation of an implant and how important that is. And what some of you may or may not know is that what makes Butterfly different from a technology standpoint is that it's ultrasound on a chip, which means one probe can image the whole body. So not only with implants assessment, but also with other assessments in your practice, like you will see tonight around seromas, but also tap blocks. So again, and it can be used for multiple other use cases, but for your community, really very important and significant use cases. And I think we've heard it from multiple plastic surgeons that you carry it around whether you're in the OR in the hospital, to your ambulatory surgical center, to the OR in your office. You will see it will also enhance your other clinicians in your office as well. And just a moment about partnering with Sientra. We partnered with Sientra very specifically, as Sientra really is a company that has been transformative in your technologies, honestly, in progressing plastic surgery. So I think that together we feel very devoted to the fact that we're raising the bar of safety for our patients. And that includes education and research. And I really commend Sientra for the promotion of putting the money back into those efforts. So thank you for doing that. And it's been a pleasure during the planning of this, both to get to know Drs. McGuire and Haas. So thank you. Thank you for committing to this practice of improving safety and compliance with surveillance. And I think we'll get on to some of the case discussions.
With that, thank you very much, Dr. Kallman, and I'll reintroduce Dr. McGuire to go through a couple of cases with us. starting with what normal looks like.
Yeah, so the most important thing, I get a lot of questions about, how do I know what I'm doing? How do I start with this? My suggestion is always when you first get an ultrasound every patient who has an implant who walks through the door. Your 6-month post-op, your 1-year post-op, because once you learn what an intact implant looks like, when you're seeing someone who you know has a normal implant, then you start to realize when it doesn't look like that, something is different. So this is a scan on a patient going from the outside in. At the top is breast tissue. This is subglandular implants. You don't see pectoralis muscle. Now, I am not looking at my patient's breast tissue. I make that very clear to them. So we're not missing cancers. You'll see a cyst or something once in a while, but I make it clear to the patients I'm not looking at their breast tissue. I'm only looking at the implant, the integrity of the implant. So once you come down through the breast tissue, then you'll see the capsule, which is, you can actually see on this patient, very thin line between the implant shell. And the implant shell looks like railroad tracks, 2 parallel lines next to each other. That's the shell of the implant. It'll look different if it's textured or if it's smooth. This is a textured implant, so the signal's not quite as bright as it would be on a smooth, and it's a little bit fuzzy. The inside of the implant is absolutely clear. Now, when you're doing these, it'll look a little, and we'll show you some examples of how it looked differently. The good thing, easy thing about the butterfly is on either your iPhone or an iPad or whatever you're using to look at it. You can adjust the gain so you can see a little bit more clearly inside, outside the implant, or differentiate between the implant shell and some reverberation artifact that you might see.
And as we change slides, as we get to a demo later on between cases, you'll see that the ability to adjust gain and depth with the app is actually quite easy once you get facile with it. It's very clear and very straightforward.
This is another intact implant. This is a muscular implant. Again, you see the intact shell. Here we're going to show a video. So this is what you actually see while you're looking at the screen with your patient. And I usually will start, everybody has a different place they like to start doing it. I'll start medially and go laterally, and then just stay in a kind of a grid so you see the entire breast, and just sweep around it. And usually as soon as you put the probe on, you can tell if there's going to be a problem. If there's the inside of the shell looks a little bit fuzzy, if there's you can see shell and extra gel on the outside of it. Usually you can have a pretty good idea of what you're seeing right when you start. And the patient's looking at this with you. So I describe to the patients what I'm seeing as well, and they love it. I mean, the patients really like this. It's makes them feel comfortable that their implants are intact, especially with the textured implant patients coming in. Instead of just telling them, you know what, I think you're okay, I can show them they're okay.
Did you do that from the very beginning? Always share images with the patient?
Always. They look at the screen with me. Yeah. Now, in the beginning, when I didn't really know what I was looking at, I would tell them I didn't really know what I was looking at. But and when I started using the butterfly about a month ago, I told now I bring both the one I have and the butterfly in the room. And I will say to the patients, hey, listen, I got this new one. You mind? Oh, they love it. The patients really they can see it. I sent Blaine a case today where I imaged one side, the implant was intact. As soon as I put the probe down the other side, the patient said, oh, that looks different. That implant's ruptured, isn't it? So the patient can see the difference.
It's just a great communication tool. And Pat has had hers longer than I, but I had a tabletop unit back when there was a lot of stuff coming out about the BioCell and a lot of different implant warnings, a lot of stuff in the media. And every time there was a new media story, we all got phone calls the next morning. And to be able to tell patients, you can come in and we'll ultrasound you. And this, you can delegate this. Again, like Pat, we tell them we're not looking at breast tissue. I have 2 nurses who can both do this so that by the time I see the patient in clinic the next week, their anxiety has already been ratcheted down because they've seen what their implant looked like. They know what's scary. And if there is something scary or seroma, my nurses can tee them up to get that drained immediately. So it's a really powerful tool that has really improved communication and patient care.
And I think the fact that you can empower your other clinicians, whether they're nurses or PAs in your office to do this, also creates efficiency in your office between cases. And again, the communication element is so key.
Yes. And as Pat said, taking this to the OR, and I've got my butterfly packed up to take with me tomorrow because I have 2 implant exchanges. So I'm not as good as Pat. Pat's probably the best, I would say. I'd put her up against any radiologist at reading an implant ultrasound. But if you can ultrasound a patient right before you open them to look at the implant, you get immediate feedback and you can confirm what you saw in the office. So it's really powerful. I love the butterfly.
Great.
Yes, so here's an
And quick-
example
quick-
of that. This patient, this was on the table. I did this imaging. I could see that this was intact. This was a textured implant. I took out the implant and the capsule, but I go in knowing, and for the nurses in the OR, they know, oh, is this one ruptured or not? Are we gonna have to have extra laps? Are we gonna need some more irrigation so that you can plan on that? And no surprise seromas.
Time.
Nothing, so you can't tell. So this you can tell is an intact implant. You can see the shell is intact, clear on the inside of the implant. And that's exactly what I found in the operating room on the left side.
And on the bottom left, you see some shadows, which really is probably just artifact that you may need some additional gel if you wanted to get rid of that. But I think the implant is very, very clear.
And so this is the patient's other breast. Image this in the operating room, and you can tell this looks different than the other one. You see the shell is now collapsed into the implant. There's fuzziness between the shell and the capsule. This is an intracapsular rupture because you don't see any gel outside of the capsule, which is not always easy to see, but it's pretty thin. But you can tell this is different from the other side. And this was right after image right before surgery. This is the ruptured implant in the capsule. This is a video of the same patient, so you can see what you see when you video. You see intact shell there, and then all of a sudden it disappears. Those two lines go away, and now you're seeing gel where it's not supposed to be. When the gel hydrates, when it gets outside of the shell and gets bodily fluids around it, that's where it becomes a sort of snowstorm appearance, where it gets a little bit fuzzy. And that's caused by the gel being hydrated. And so now you see the more fuzziness inside the shell of the implant, plus there's gel on the outside. You can see the capsule pretty well on this one too. So again, this is an intracapsular rupture.
Yeah. Have you used this for education with the residents in the ORs?
Yeah, I actually have residents tomorrow coming, and I have a ruptured implant case. I have one side intact, another side ruptured, and I'll have the residents scan them before the case and see what they think.
But I think Blaine brought this up too. This is the other thing. We've all gone to the OR with somebody we thought had totally intact implants. It's a simple switch out. And then you get in there and it's ruptured and it's a mess. And you've added an hour onto your day that you didn't plan on. This lets you plan much more effectively and know what you're going to head into in the OR. Know if you've got all the right equipment.
Well, and I think it's also really important in the age of ALCL, not if you're a patient with a capsular contracture. I've been called by surgeons to have a patient in the OR. All of a sudden they had a cap count. All of a sudden there's fluid around that implant they weren't expecting. What do? Well, I'm too old to be surprised anymore. I don't need that kind of stress. So if you have this ultrasound with you, some of these patients, I've seen them 3 or 4 months ago, and I may have ultrasounded them then and there was nothing going on. Now you get in there with this butterfly. I ultrasound every patient right before surgery and there's no surprises.
Right. I think it's really interesting you spoke about that imaging every time you see them may change longitudinally in terms of what you're going to expect. And I think that really, again, changes their management.
So here's another.
I think overall, these are great.
Go ahead.
I was just going to say great points, to, especially use on the OR. One, as people have got the butterfly recently and discuss it with me, the OR seems to be the best place for them to confidently educate themselves pre-op before they sterilize, scan it, and to Dr. McGuire's point, then you go immediately in and confirm what you saw, and you'll be able to see both normal. So huge recommendation if and when you get the butterfly, take it in the OR for abdominal cases and breast cases, certainly revision breast cases, and that your learning curve will be much steeper. But also, with the ALCL point, you want to be prepared if you do have that fluid. You don't want to find that abruptly in the OR, not be prepared to collect that in the correct heparin vials. If you weren't prepared, you may lose that fluid and not be able to send it out for testing.
Any comments on your learning curve on using the device?
I am the most untechnical person you can imagine. My
I don't
husband
believe
was
that.
like shocked that I could actually do this. I went to Brad Bankston, who taught me how to do it. I went to his office and spent a day. He had an ultrasound PhD guy who lectured to us. It all went over my head. And I'm like, oh my God, I'm never going to be able to do this. And then we brought it into our office. We had a few staff members that had implants, so we imaged them. And then every patient that came in, my first ultrasound was not portable. So I was not able to take it in the operating room. I actually think now that might be a good idea, to make you're more comfortable when you're doing it in front of a patient at first, is to do it with a patient asleep. But the learning curve is not long. Once you learn and when I first started doing it, if I thought the patient had a ruptured implant, and that patient said, well, I'm only going to have surgery if there's a confirmed rupture, then I would send them for an MRI or send them to a radiologist for a confirmatory. I don't do that anymore. I don't, I track this, every case. I photograph the picture. I have my ultrasound photographs so I can go back and refer. And the learning curve is not nearly as long as I thought it was going to be. Mindy, how about you?
Agreed. It is definitely not as long, and especially with the butterfly being able to scan immediately and then open the breast, it's immediate feedback. And all of us, that's what we thrive on as surgeons. So
Like
it really is.
Immediate decision making. But I just want to say, in terms of learning curve, as a cardiologist, I'm actually now starting to be able to read the images. So I'm finding that Blaine's an expert, so that works.
Yeah. It's funny how much I don't even scan real patients. I've just done phantom models, but I'm getting all these views. We've got a team of about 10 surgeons across the country, both cosmetic and reconstruction, uploading images so that I can actually collate them. And that's part of our, again, commitment to the education, is webinars like this to show what normal looks like, show what ruptured looks like, show seroma, so that you have a point of reference. I think when Dr. Hawes and Dr. McGuire probably started, there wasn't a library of those references, so you had to kind of figure out normal on your
We
own.
called each other, we texted each other.
Let me text you the scan. What do you think?
Well, that's actually a very good point, because just to be very specific about the technology, it connects to your phone and then it goes to the cloud. And in the cloud, these images can be shared amongst each other if you make allowances for each other to view. And that's really important.
And they're de-identified, which is nice
exactly.
too.
Completely secure, completely HIPAA compliant. But that communication from physician to physician also is extremely important. And we also have educational videos embedded in the software. So again, that can also augment your education learning curve as well. So it's really all there in the software.
So I think this is a video of another rupture.
Yeah, let me go back and show the video really quick. There you go.
And so again, you see this is a submuscular implant intact. You see how the shell collapses into the implant. All of a sudden, you don't see that shell anymore. And you see the snowstorm effect. And it's pretty obvious it's not the same as an intact implant. And this was, this had some intact shell, and then you go further along and you see where the rupture is.
And I think that's why it was important to show normal at the beginning, exactly where Blaine is outlining. Those two lines are very clear. And then when you lose that continuity is you see the difference.
And I was concerned changing to butterfly, that my big $15,000 tabletop unit, like, oh my gosh, is this going to be I was really surprised how clear the images are, how I can visualize. And there's some things, I think, because of the frequency of the ultrasound, there's some things that actually, like larger breasted women, this actually is a little bit better for those than my tabletop version of an ultrasound. So it's very, I was honestly very surprised at the quality of the images with the butterfly.
Yeah, I think that's an interesting point, because it's ultrasound on a chip. It has a range of frequencies built into the probe. So it's versatile, and it kind of shifts back and forth between what's needed to be scanned, of which I'm going to introduce Julie in a moment, which she will speak to. But those frequencies are there for allowing the versatility, which really makes kind of different images of different body habitus, I would say. Is probably more easy.
That was actually, as a technology nerd, what attracted me most about Butterfly and partnering with this company specifically, is they've innovated the technology where they're not actually using physical piezoelectric crystals to create ultrasound, which can burn out, and you need multiple heads for different application depths. That they've actually, that is the innovation that came out of the Bill and Melinda Gates Foundation backed kind of innovation lab, to be able to build that chip to allow multiple arrays in a single device. So it allows, it's really the software that creates the updates to create the new presets and such. So as we move forward as partners in plastic surgery, again, industry and surgeons, then we can add more education videos directly to the app, and it just uploads quickly, once they push it out to you. And that can happen daily, and it just takes a couple of seconds. And then also the presets, as they innovate for specific things around plastic surgery, it'll just come as an automatic update. So with that, yeah, Dr. Coleman, if you want to introduce Julie for our kind of demo.
Yes, absolutely. And so I'm going to introduce Julie West, our expert clinical application specialist from Butterfly, and she's going to show some of the straightforward demo aspects of using the technology. So thank you, Julie.
Thank you, Dr. Kaleman, and welcome everyone. So as Dr. Kaleman said, I'm going to give a brief demo of the IQ, the functionality of the app, how it works from beginning to end when you're scanning a patient. This is the transducer itself. And as Dr. McGuire was saying, it's highly portable and it's really easy to operate. I'm going to share my screen here now so that we can take a look at the app itself. Okay. So I'm using an iPad mini right now, and all I'm going to do is just plug the probe cord into the charging port on the device. So now that I've plugged it in, it's automatically going to take you into the app and you're ready to begin scanning. I'm going to actually scan. I have a tissue phantom here that has a smooth surface breast implant in it, just for demonstration purposes here. But as you can see, so most ultrasound systems, as we were talking about the traditional ultrasound systems where you have to purchase multiple probes that plug into the ultrasound system itself, a lot of those have about 50 to 100 knobs as well. So it can be very intimidating to learn to use. We've simply put 4 controls here at the bottom. Just by adjusting your depth, things are happening in the background automatically, such as your frequencies being adjusted, to where you don't have to worry about manually adjusting all of those controls. So the very first thing we're going to do is select the preset. And the preset we found that's best for imaging the breast implant is the MSK soft tissue preset here. So just by tapping on that, it's going to activate the appropriate probe, put us at the most common depth, the frequency. It's getting us to a good starting point so we don't have to make a lot of adjustments. So now as I'm scanning my tissue phantom here, we can go over the 2 main controls that you'll be using throughout your scanning, which is simply your depth. And all you do is slide your finger up and down on the screen anywhere, and that's going to adjust our depth for us. So I slid my finger down and it made our image a little shallower. And if we want to see a little deeper, just slide your finger up and then that will increase our depth. And as Dr. Kaleman was talking about with the frequency ranges, it's from 1 to 10 megahertz. So as you're increasing and decreasing your depth, it's automatically changing that frequency for you depending on how much penetration you need. So for example, if we're just looking shallow here and examining the shell, we can see all those nice layers. But if we wanted to see more posteriorly and we increase the depth, it's now putting it at a lower frequency for us so we can see more posteriorly. We can even see the posterior patch right here on the back of the implant. And your other control is your brightness or your gain. And just by sliding your finger left to right on the screen, so I'm sliding to the right now, and we're increasing the brightness, and sliding to the left will decrease our brightness. It's also really simple to capture an image. So down here at the bottom, you'll see our little snowflake. So when you tap on that icon, we now have a frozen image, so we can capture that tapping on the camera. And as you're going through and capturing all of your images, they'll be housed here temporarily. So we have 1 image in our capture reel right now. Nothing is stored on the device itself, on the iPhone or the tablet, obviously for HIPAA patient privacy. So they'll just be stored here until we send them off to the cloud. And now while we're scanning live, you'll notice this icon is a video camera. So we can actually take video clips as well, as we saw earlier. So right now I'm just scanning around, getting my clip, and you can have a clip up to 1 minute long. So once we hit stop here, it has taken that clip for us. And again, it's up here in the capture reel. We'll unfreeze. And you will notice now, so we're frozen and we can add labels and annotations as well as measurements to the image. So if you wanted to label, it's as simple as typing it in. So we can just manually type, so right breast. And when we hit done, we're now going to have that annotation on our image. And if there was something there you wanted to measure, say you saw a seroma and you just wanted to get the dimensions on that, we can pull up our measurement tool. And just by using our finger, we drag over the blue dots there and we can get our measurements. All right. And it would be the same for, say, your tap block procedure. We can go into presets. Tap block also looks the best on the MSK soft tissue for most patients. So you can reselect that. And now we can take a look there. Some nice cold gel on my skin there. So as you can see, we've gone from scanning the breast implant to now looking at the area where we could perform our tap block. And for your procedures, we have tools under the actions menu. All of our advanced tools are housed here, where we can actually activate a needle visualization tool. So when we turn that on, when you insert your needle, it will put a bright blue overlay on top of the needles to help you see it. We also have color Doppler and power Doppler. So if you needed to assess for any blood flow before your procedure, make sure there's no large vessels in the way. This would help you see those vessels and fill them in with color. All right. We also, up here in the top left-hand corner, this is where you can review all of your images and share them. So this is kind of like access to the cloud. You can access the cloud via the desktop, which we're going to look at in a minute, or you can look at them right here from this area. So we'll see all the prior patient studies here, and it's really easy to share these as well, which we're going to go through in just a moment. Okay, so now we've taken all of our images. We are ready to send our study to the cloud. So all we're going to do here is come to our capture reel. And this is where we can now add those patient details. So we can type in the patient's name. Let's see. You could even add their medical record number as well down here at the bottom, as well as date of birth. And we'll save that. So now we've attached those images to a patient. If you'd like to add any notes to your study, you can add those here. And then down below here, we'll see all the captures that we took. So from here, if you just wanted to share a single image, we could tap on that. And right here's the share icon. We can tap on that. And right from here, we can share that de-identified study. So I'm on an iPad, so I don't have texting. But if you were on a phone, you'd have texting. We've got AirDrop. You can email it, whichever way your smart device allows. Okay. We can also add labels and measurements before sending to the cloud as well, if we didn't do it as we were scanning. So now we're ready to send it off to the cloud. Down here, you'll see your saved study. We'll confirm that. And now we can take a look at what the desktop cloud looks like. Okay, so now we're viewing, I'm logged in on my desktop. This is the Butterfly Cloud. So this allows us to actually open up the study we just performed. And we could take a look at the images and the video clips larger. And you'll see also we can still at this point add measurements and annotations to our images. We could also flip through all the images. So it'll play our videos for us as well. All right. And then let's take a look at how to share them. So right over here is our share button again. So what it'll do is it'll actually give you a link that you can now paste into an email and email to your colleagues. Also, when you're logged into the cloud, you'll see education. So as Dr. Kaelman was saying, we have a full library of educational videos. You can view these on the app itself while you're scanning, or you can view them right here from the cloud. Back to our cloud. Okay, and I'm just going to stop sharing here for just a minute. So that is an overview of the IQ and the Butterfly Cloud.
Great. Thank you very, very much, Julie, for that wonderful presentation. And I'll also just say, I think just a comment about the presets. I think what you emphasize is that it's less intimidating than having to choose frequency or type of probe, especially when you don't have kind of the extensive physics training that one may have had growing into it. So really the wide range of frequency does choose it for you. So I think a lot of the way that it's navigated becomes part of just your workflow, which is great.
So with that, back to you, Dr. McGuire, on more of a seroma case.
Yeah, so these are the kind of cases when you say, thank God I have an ultrasound. This woman called on a Wednesday and said her breasts had been swelling over the last 2 weeks. She was leaving to go to Las Vegas Wednesday afternoon, and somebody comes in with this much swelling in the breast, you'd think they'd be in a hurry to have something. They would have come in sooner, but she comes in, she's leaving town, and she needs to have something done. She's a textured implant. This is an old implant, it's been in for a long time. It's a macro textured implant, and she has this obvious swelling of her breast, and my heart's in my throat. So I ultrasound her, and you can see the shell of the implant, and then it's clear on the inside, so the implant is intact, but it's also clear on the outside of the shell. So that's a seroma. This is so now my heart's really in my throat, and I'm thinking, okay, what am I going to do? This is the video. Now, interestingly, on this one, it looks like on her, all of the swelling looked like it was at the top of her breast. So if I was going to put a needle in it, that's where I probably would have thought, because that's where most of the firmness is. But when I ultrasounded her at the top of her breast, there was no fluid. The fluid in the was all in the lower pole of the breast, and the implant was floating up on all of that fluid. So if I had just put a needle in without having ultrasound guidance, I would have stuck her implant. Now, a lot of people will say, well, aren't you worried about sticking the implant? No, this woman with this is going to have an operation. You have this much of a seroma with an old implant. There's something going on there. Now, I will say I had diagnosed my own patient with ALCL 2 years ago through ultrasound, and the ultrasound did look different than this. It's kind of the fluid where it looks fairly clear. When you come around that corner again, you'll see it gets a little bit different. There's a little bit more right there, a little bit more less pure fluid to it. So using with my nurse, we have sterile gel. I did an ultrasound guided aspiration. Rather than trying to scramble and find a radiologist and then hope the radiologist knows what testing to do when you get fluid out, I do this myself. I aspirated 200 cc's of bloody fluid from her. And when you see bloody, it's much like ALCL is a cloudy yellow fluid, the most part. So now it's, instead of aging me like 100 years, now it's like 20 years. But I'm able, within seeing this patient, 15 minutes later, I've aspirated this fluid and sent it off to pathologist. And this was a case from 2 weeks ago. And if this was negative for ALCL, then she's scheduled for an implant removal with a capsulectomy.
So where you put the needle actually was changed by your use of the ultrasound.
But the ultrasound made all, because this is one where she's very uncomfortable with this, and you want to do something, and to me, if you said, where are you going to stick this needle, I would have put it at the top of her breast, because that's where it was tight, that's where it was hard. And with the ultrasound, in the bottom of her breast was actually very soft. And I would not have thought to put the needle where I put it. And this is where the ultrasound guiding you to where to put it is key. And these people usually come in Friday afternoon at 5 o'clock, with this. And it's nice to be able to get the process going to get a diagnosis on them without having to, scramble around. And, I had a patient who was uninsured and had a late seroma that I aspirated. Was able to get the fluid sent off instead of trying to find a radiologist who's willing to see an uninsured patient. You can my patient of my own that I diagnosed with ALCL, from the time of her first symptom to her diagnosis was less than a week. And she had a stage 1A ALCL, and the ability to make an early diagnosis, getting that patient in, getting the ultrasound done, getting the fluid out, sending it off could be life-saving for these patients. So I think it's, I say, I don't know what I would do without an ultrasound anymore.
And it's a differentiator, right? Because when you see a patient for primary augmentation, you can say, and part of the follow-up, the FDA now will accept ultrasound versus MRI. I have an ultrasound. You come see me if there's a change in her breast. To Pat's point, it makes me feel better to be able to look at those implants and know, so that I'm not waiting to hear from a radiologist or to go the back and forth. We're afraid to stick the implant. Please stick the implant. Just get the fluid out. but it's also, we've all had seromas with tummy tucks and other places. This works there too. You can reassure yourself you drained a seroma completely, whether that's the breast or not.
And I do want to just comment, because you said this about access to care and about an uninsured patients. I mean, one of certainly the mission of this is, because it is so accessible, is that we can bring care. We all treat multiple types of patients, and we can bring care to all of them. And it's the same quality of care with technology. And I think that is certainly a priority for all of us.
Yeah, agreed.
And now we're mentioning other utilizations in plastic surgery. And Blaine, do you want to, this is for a tap lock, which Butterfly is excellent in terms of imaging. On the right-hand panel, you see an actual ongoing video of you can see the needle starting to go in. This is a longitudinal view. At the same time, if you wanted to use some of the advanced tools, you could put on color flow to make sure that it's actually not a vessel, which will be extremely important, so that you're injecting right into the right place and you can see the needle going in at the same time, take a video and know where you are. So again, for abdominal procedures and tap locks, very, very useful. And again, in your office, and I think it was Mindy who said it, somebody may say, I came in for one thing and now I'm coming in for something else as well, because that, you know, it all becomes, you know, kind of comprehensive in terms of delivery. And if you see, this is actually another feature you're going to see as we play the video on the left, is that one of our advanced tools and innovative tools of our software is called Needle Viz, or the ability to visualize the needle going in with this nice technology you'll see. You see it.
I'm Teresa Lopez,
There we go.
Clinical Product Specialist with Butterfly.
Thanks.
I'm going to show you the Needle Viz in-plane feature on the Butterfly iQ+. This feature is useful for in-plane guided procedures such as central line placement and peripheral IV sticks. For today's demonstration, I will be on the vascular access preset. I'll begin by finding my region of interest, and then I will select under my actions menu the Needle Viz feature. Now I will take my needle and approach in plane to see
Wow.
the tip of the needle and
Nice.
the shaft as it approaches the vessel.
This nice blue sword moving in, and there it hits the vessel and it's in.
And that's an example of the in-plane Needle Viz feature on the Butterfly.
Now that would be equally the same view you would get for a tap lock. And
That's fantastic.
Yeah, that is fantastic. I didn't know that.
I didn't either. I just learned
When do you
something.
guys think
Glad I'm
about
here
using
tonight.
that for?
Now you're going to be using that, but an
was gonna say-
important point for your
It
practice
is
is
an
that,
important point.
if you're working with anesthesiologists, they could be using this for vascular access, so it becomes multiple usages. But you would probably use the color flow at that moment as well in a tap lock to make sure you weren't going into a vessel. So again, another really very cool, a cool element of this software.
Very cool.
From an education standpoint, it might be great for residents, especially with everything that we've gone through with Brazilian butt lifts and avoiding injection into the muscle and the vascularity. Even if you don't want to use it for actually doing that, just teaching the residents on that anatomy and seeing that, I think is again another point that can bring safety to the market. And so this is where we'd love to open up the discussion. I think we've had great discussion from the panelists along the way. So I'll just go ahead and stop share, and we'll put it in gallery view. And this is where I think we should go to the chat and take some questions. Dr. Kallman, have you seen any that we should start with? I definitely have one or two that I've seen come across.
Yeah, and I'll ask the doctors actually. It's one of the questions is great. Can you discuss your workflow and how you then kind of incorporate it into a visit, capturing the images, and then how you upload it? Are you doing it all in real time? How do you kind of go from step to step?
So the way I do it with patients, when I have a new patient come in, let's say or a post-op patient that I know I'm going to ultrasound, I will, depending on what it is, my nurse will go in and do a quick scan. If she sees something abnormal, then she might say, hey, go see this post-op patient, go see first and then come back in here to do something else. For new patients, what I do is see the patient first. Let's say it's a revision case. I'll see the patient, talk to them about it, have them undress, examine them, and then bring the Now with this, I'll have it in my pocket and then pull it out and do the scan with the patient looking at it with you. It actually makes my office hours much more efficient. You know, if you have a patient, especially when we went through the BioCell recall and every 5,000 patients calling, you know, sure, their breast is swollen, we could get the patients in. And instead of, you know, talking and saying, well, I think your breast is okay, and I think this is fine. When you get that ultrasound and you show them, here's the shell of your implant is intact. There is no fluid around your implant. All of a sudden they just relax, and you can, Mindy, you visibly see it, don't you?
100%. And we started with, just as Pat said, we're sure this is going to completely destroy the office. It was going to take so much more time. We started with having the nurses pre-scan these patients that called. And it evolved to, it really didn't add that much time. But for people who were really anxious, for them to be able to get in within a day or two to see the nurse, so that when they saw me, that they were ratcheted down, and then I could go to the point of most concern and look at it with them again. It's unbelievable how you just communicate better. They're like, patients are like us. They want visual cues as well as verbal cues. And if they can see the implant while you're saying your implant's fine, and they can see their implant's fine, it makes the whole thing go much quicker.
Yeah,
much less talk.
Yeah, it's
And for
fascinating.
the really nervous patients,
Absolutely.
you want to come in once a month, you want to come in every 3 months, my nurse can quick scan you, fine. You know, it's a service to the patient.
Not gonna be everyone.
The only problem is it's so interesting that it's easy to start scanning when you see something and then keep scanning and keep. So there are times where I have to say, okay, stop it. I had a patient I had read as a ruptured implant a few months ago. I got her into the operating room, and it's like, okay, this wasn't, when I got in there, the implant was intact, but she had had a previous operation and she had siliconomas around the her capsule, and I was like, oh my God, the implant's intact. Well, when I looked at it with the butterfly right before, I was like, okay, wait a minute, this implant is intact. What am I seeing? And there were a couple places that were fuzzy, and it was silicone from a previous ruptured implant that I was seeing. So it always tells you what's going on. You just have to start listening to what it's telling you, or speaking the same language to understand.
Got to be able to interpret.
You know, I think it's fascinating because we hear multiple different physicians from different specialties before they start using it, think it's just going to increase the time in their office. That's often a very common statement, that it's going to interrupt their workflow, whether it's a primary care or a cardiologist having it in their hand. And I think when people get adept at using the technology, they feel the opposite, that it just changes the efficiency, which is really exciting.
So let's go on. There's a couple of questions that I think are connected, and so let's have a discussion around what consent you're doing.
Great question.
Which I think is connected to, you know, how you look at this. Is it a subjective analysis tool just for your information, maybe that patient's information, or do you really want to hold the studies, keep them, and the liability with that, and therefore the consent that to be specific to what you're looking for? And then after that, maybe we'll move into, there's been questions about coding and you know, being able to code for this, especially from the reconstructive space. So let's start with consent. What kind of consent to use and education do you do with your patient to make sure that you're not held liable for missing a breast lesion?
I have a consent that Caroline Glicksman, who just got her master's in law, who's a plastic surgeon, wrote and ran it by Bob Asher for the Aesthetic Society. And it's specifically, you know, it's the usual thing. What are the risks? What are the benefits of doing this? What are all the alternatives? And then we have a paragraph that specifically says this is only for breast implant imaging. And we are not looking at the breast. We recommend, you know, the American Cancer Society screening tools to look at your breast tissue. And also that, you know, as an alternative, you could get a confirming MRI. And, you know, we're looking for ruptured implants. We're looking for seromas. And we don't, you know, we're not looking at anything in your breast, which I think is where the main liability would be. And every patient signs it that we ultrasound.
Yeah, and I think that's it's incredibly important, because we would say the same thing, that this is for surveillance and not for any identification of breast abnormalities.
And I just say, I'm good at look at the implant shell, pretty darn good. I think my success rate is about the same as an MRI or an ultrasound done by a radiologist who doesn't look at implants all the time, but I'm lousy at looking at your breasts. So let's
Right.
just be clear about that.
Yeah, and I
think-
give every patient the option to have an MRI, confirming MRI
Absolutely.
if they want.
And you actually have them sign a consent in the
They
office.
sign a consent. It's in everybody's chart that we ultrasound.
Yeah, I think that's important.
Time check, we're at an hour. So thank you guys very much for all the discussion. Not to put you on the spot, Dr. McGuire, but you talked about your consent that Dr. Glitzman helped prepare as well. I'm getting blown up on text and chat of whether or not you'd be willing to share that template that Sientra can share out as a resource.
Yeah, I'll send it to you.
People who buy.
I'll send it to you,
Yeah,
Blaine.
and then we'll make sure and get it as a resource for sure. Okay.